Hello and welcome to Live Doctors. My name is Charles Siminoff. I'm a family physician in Manchester, England, and we're very lucky and privileged today to have Dr. Douglas Drossman speaking to us on functional gastrointestinal disorder. Dr. Drossman graduated from the Albert Einstein Medical School in New York and has since worked in gastroenterology and psychiatry in both New York and in North Carolina. He's a world expert on the treatment of gastrointestinal disease involved in the bio-socio-psycho aspects of the disease, and I'm delighted to be able to speak to you today.
Well, thanks for having me.
Could you start off by giving us a definition of functional gastrointestinal disorder?
Well, that's actually a somewhat complicated question. If you ask most people what a functional GI disorder is, including physicians, they'll often say the absence of organic disease, meaning you don't see ulcers, you don't see inflammation, you don't see anything.
Yeah.
That evolved to be more of a disorder of motility. It was thought that this has to do with spasm of the gut. But nowadays, we're in a whole different era. We're looking at it as disorders of gut-brain interaction. And what we mean by that is that there is a connection, a hardwiring between the brain and the gut.
Yeah.
And as a result of that, abnormalities in the regulation of that may lead to symptoms like pain or altered bowel habit, leading to what we call functional GI disorder. So we're trying to change the name from functional, which can sometimes be stigmatizing, because when you don't see anything on X-ray or endoscopy, patients think, well, maybe I'm crazy.
Yeah.
And we're trying to change that stigma. So we're now saying disorders of gut-brain interaction.
Right. I think that's a useful distinction. When I was a medical student, if anybody suffered from any gastrointestinal problem, there was a whole battery of tests you did in order to rule out any physical disorder. I think, as you say, we've moved on from there because more often than not, the results will be negative. So you then have to work on what is actually going on between the brain and the gut, presumably.
That's right. And actually, I'm part of an organization called the Rome Foundation, which is involved with developing criteria for these functional GI disorders because the absence of disease does not define anything. We're really looking at how we're using positive criteria to define these syndromes.
Could you just go through the actual symptoms that the patient would be complaining of?
Well, functional GI disorders in general are abnormalities of gut function. It could be diarrhea, constipation, nausea, vomiting, abdominal discomfort. And then we partition that into specific syndromes like IBS or functional dyspepsia and the like.
Would it be standard routine to go through physical tests to exclude any other reason, for argument's sake, if there's a tumour or if there's an ulcer, or is that now thought not to be worthwhile putting the patient through that?
It's really two parts. What you're doing is you're looking at the symptom profile, and you're seeing if it meets certain patterns. Irritable bowel, for example, is abdominal pain associated with change in bowel habit. It could be diarrhea or constipation with bloating. Once you hear that, you say to yourself, well, there are other things we need to exclude. Is this inflammatory bowel disease, ulcerative colitis, or Crohn's disease? Is it celiac disease? So once you have the symptom criteria, what you're really doing next is you're trying to do a minimal amount of studies to exclude other disease. I think the risk in our society is over-treating, is really doing overdiagnosing, really doing too many studies, when if you have a positive diagnosis and a minimal number of studies, you're okay.
In other words, you can make the diagnosis mainly from the history.
Very much so. Most expert, good clinicians know when someone has IBS, but you do need to do some studies to exclude the other possibilities in a smaller percentage.
Are there any specific risk factors that patients presenting with these symptoms that you could say, well, you're more likely to get it or you're less likely to?
Yeah, I think there are certain basic differences. We know that women are more likely to get functional GI disorders than men. About 60% of people with functional GI disorders are women. There are differences in healthcare seeking. Women are more likely to go to the doctor, so in the clinic it could be as much as 80%. Another risk factor that's very important is the presence of early infection. If you have a prior infection, we often call that post-infection IBS or post-infectious IBS, because the infection, and these days the whole idea of the microbiome, which we may get into, the bacterial flora of the gut, can play a role in altering gut function. And then, of course, you can have dysregulation of the brain-gut communication, where early trauma, sexual and physical abuse, psychiatric comorbidities like anxiety and depression can worsen these symptoms.
Are there any dietary factors that could be significant?
Well, these days we're starting to look at the role of food and diet. I think in terms of the treatment end, we're looking at certain substances that might not be absorbed and digested as easily, and they stay in the gut, and the bacteria kind of chew it up and produce gas. We talk about that as FODMAPs, high FODMAPs, fermentable oligosaccharides, monosaccharides, disaccharides, gluten. These are substances that can lead to an increase in symptoms. It's not a risk factor for development of IBS as much as it's a factor that leads to flare-ups or worsening symptoms of IBS.
We hear a lot about the Western diet, obviously contributing to an increase in diabetes and heart disease and obesity in general. Is there any connection between obesity and the increase in, say, sugar with bowel symptoms?
Not to any great degree. We actually did do a study where we put people on a low carbohydrate diet, actually the Atkins diet, and found improvement of symptoms. So there is to some degree, but there's a lot of individual variation.
Functional gastrointestinal disorders, is there any ethnicity changes that you find amongst the population?
It's a global phenomenon. Everybody has IBS. Everybody has functional dyspepsia. I don't mean everybody. Every culture has it. But what's different is often the representation of that, how it's experienced. For example, bloating is a very common component of irritable bowel syndrome. Patients have bloating. In China, it's almost a definition. You have to have bloating to have irritable bowel syndrome. In Latin America, there is no word for bloating. They call it inflammata. They have no expression for it. So we have to, one of the things the Rome Foundation is doing is finding ways to understand this across cultures. So it's not so much that the symptoms occur or the changes on the body occur, but culture affects the symptoms and the way they're reported. So someone in Latin America won't say bloating. In China, for example, they describe pain differently from Western cultures in that they often think about pain in terms of hot and cold. Their symptoms feel cold. Now, we have no representation of that, but in their culture, they do that. So that's an example of how we have to understand their symptoms somewhat differently.
It's very interesting because I do remember a Chinese patient I had who kept complaining of burning in her
That's
back.
right.
And it was after a while, I thought it was obviously some sort of burning pain that she has. But thank you for that.
Yeah, in fact, in Western cultures, the only, sometimes they'll say have freezing pain. Yeah. The only place that has been shown to where people in Western cultures say freezing is dental pain.
Yeah.
So again, cultural differences.
And what about age differences in the presentation of symptoms?
Irritable bowel syndrome is more common in people of young to middle age. It begins in adolescence or even late childhood, 8, 9, 10. It seems to peak in the 20s and 30s. And then as you get older, people still have it, but there are differences, more subtle differences, more constipation as you get older. And it may be that people adapt to it differently. I think as people get older, the symptoms don't seem to be as disruptive in their life. Perhaps you adapt to many aches and pains as you get older.
is it still relevant to discuss the type of personality of a sufferer?
Not to a great degree. I do think that when you have psychiatric comorbidities, you tend to have worse symptoms.
You're instrumental in setting up the Rome Foundation.
Yes.
Can you give me a brief outline on where it's up to now and its current developments?
The Rome Foundation is an international nonprofit organization that's mission is to help patients with functional GI disorders. And we try to do that by promoting scientific investigation in the area, supporting research, and also educating. What we have done is much like in psychiatry, where you have the categorization of these diagnoses, DSM 1, 2, 3, 4. We now have Rome 1, 2, 3, and 4. Mm-hmm. Rome 4 was launched last May, 6 months ago. And Rome 4 is now the categorization of these disorders and the use of diagnostic criteria. See, the foundation began about 25 years ago, and at that time, when you did studies on these functional GI disorders, you'd have some patients with pain, others with diarrhea, others with constipation, and they were so heterogeneous you couldn't determine if a medication was helpful or not. But by precisely defining and classifying these disorders, that allowed for the FDA in the United States and the EMA in Europe to say, we now have a handle to do the research. And that is what led to the development of the functional GI classification system. And since that time, we're now moving toward education of clinicians, not only using the criteria, but through teaching them how to make a diagnosis through algorithms and how to do treatment from a multi-component framework. So it's a lot of work.
Sure. Presumably, part of your remit is to get medical students through to qualified physicians to actually take on board the concept that we've now probably beginning to accept that there is a very close relationship between psychosocial symptoms and physical symptoms.
Yeah, and it's really a tightrope. We don't want to give across the message that these are psychiatric conditions. They're absolutely not. They're not related to psychiatric only as much as psychiatric conditions can worsen the symptoms. But it's a problem in the regulation between the brain and the gut. This is where we're looking now.
Would it be more accurate to say psychological and that behavior is involved in it?
Well, we say biopsychosocial.
Right.
Okay? So we have the biologic substrate, and psychosocial factors may amplify or modify. And it works the other way too. Conditions like hypnosis, cognitive behavioral therapy are well recognized to improve the symptoms by giving patients a better sense of control and also by actually affecting these brain-gut communications.
You've been involved in teaching the doctor-patient relationship. That is key to the patient having trust in the physician and also being able to accept what the physician feels is best treatment. Can you just expand on what you're working with that?
Well, let's think about these conditions. Someone goes to the doctor and they say, I have this pain, and the doctor does a medical evaluation. They do some studies, and what do they say? We can't find anything. There's nothing wrong. Learn to relax. It must be stress. How does the patient feel? Well, the patient feels somewhat delegitimized. They feel they don't really understand, and they'll say to themselves, well, I just need to go to another doctor till they find something, which won't happen because there won't be a structural abnormality, or they'll say, maybe I'm crazy. Very bad situation. But if the doctor says, I understand you have a real medical condition, here are the criteria for it, even though the studies are negative, that means we're not finding structural abnormalities, but you have a disorder of gut-brain interaction that's producing real legitimate pain. By providing that validation and that education, the patient can accept it. And then you can use other methods of communication, such as, we need to work together on this. You've had this for 20 years. I understand it's been a challenge for you, but if we can get you 25 or 30% better in a few months with treatment, would you be satisfied? Now the patient is not only feeling validated, but they're given a sense of hope. And in addition to that, it becomes a collaborative. This is, the Institute of Medicine in 2001 talked about crossing the chasm between patient and doctor, because in the traditional ways, the doctor's up here, the patient's down here, very hierarchical. Here we need to get the patient involved in management. So if we start to make recommendations where the patient makes choices, here's treatment A, it has this effect and this side effect. Here's treatment B, this effect, which would you prefer? Now the patient is not only engaged, but they're participating. And most of the clinical outcome research shows that improvement, positive clinical outcome is based on the patient's sense of responsibility for their self-care. If they keep going to the doctor and rely on the doctor, there's a problem in two ways. One, the patient feels powerless. And second, the doctor feels intruded upon. They keep coming back, and I can't find the right answer. But if you work collaboratively, then you're sharing the responsibility.
Yeah.
That's communication.
Yeah, I have had experience where I have sent patients to a physician, and they have come back to me saying, the physician says, I can't find anything wrong with you. Does it mean I'm imagining all this, doctor? Now, I think there is an educational matter that people and doctors have to be trained to realise that just because you can't see anything doesn't mean that there is no problem there.
Western society, and I say Western because we don't see it to the same degree in Eastern cultures, is caught in a concept of what's called biomedical reductionism or dualism. It's either medical or psychiatric, mind or body. And that's what has led to this problem. I think the history of this is very interesting. The whole idea of this mind-body dualism really goes back to the 1700s, 1600s. René Descartes.
Yeah.
He basically at that time, and the reason why it relates to medicine is that at that time, the human body couldn't be dissected. And the reason why it couldn't be dissected is the spirit was thought to reside in the human body. Here comes Descartes. He says that the mind and the spirit is separate from the body. The body is machine-like. The mind and spirit are separate. What that led to was human dissection. Human dissection led to the understanding of ulcers and cancer and morphologic abnormalities. Now that then led to us understanding medicine in terms of morphology. X-rays, histopathology, nuclear imaging is all based on what you see. That's very different from what the patient experiences. And at the time, the reason why the stigma occurred is that if someone had abnormalities of behavior or symptoms that weren't visible, at that time it was considered a spiritual problem, possession. And they went to the asylums. Yes. And the asylums were places where you couldn't study. In fact, it wasn't until the beginning of the 20th century when mental illness was put in the medical curriculum because it was considered not amenable to the same study. So as a result, the stigma has stayed that if you don't find something morphologically, then you have something psychiatric or not real. Yes. Nowadays, because of our understanding of brain-gut communication, altered microflora, visceral hypersensitivity, all of that, it leads to a different understanding disorders of GI function. And that's what we're trying to do, is to promote a very different understanding from this dualistic concept.
As a practicing physician, when a patient comes to you and you've made the diagnosis, can you give some outline on the treatment that would be involved for the patient? Sure.
Let's take irritable bowel, for example. So irritable bowel is abdominal pain or discomfort associated with diarrhea, constipation, symptoms of bloating. Well, the first thing you need to do is, do they meet criteria? And then you start to look at the subsets. Irritable bowel is different things to different people. Some have more diarrhea, some have more constipation. Once you've determined the subcategorization, you can look at treatment options. And there are many treatment options, and it has to be profiled to the individual needs of the patient. You also have to look at the severity of the symptoms. If someone has occasional symptoms once or twice a month that doesn't interfere with their activities, that's a different kind of treatment than it would be if someone has severe, constant pain, unable to go to work, unable to go to school. So in terms of treatments, in the mildest form, You might use probiotics. You might make dietary changes. You might use antispasmodics. Now, once you move up to more severe symptoms, if they're predominantly constipation, you might use fiber, but that can worsen pain. Then you might go to medications that treat constipation. There are agents like chloride channel activators. I mentioned medication specifically, lubiprostone.
Right. Could you give a brief, for the layman, what sort of treatment would that involve?
So if you have constipation, you have to increase the fluidity of the bowel, because with constipation, you're working with slow motility.
Right.
So things move slowly, and the reason why you get constipated is that the stool comes into the colon as liquid, and as it moves along, the liquid is absorbed.
Right.
But if it goes too slow, too much is absorbed, you have constipation. Right. So medications like what's been called PEG solution, Glycolax, Miralax, those kind of medications are agents that increase the fluid of the bowel.
Right.
There are agents that secrete fluid. These are called the chloride channel agents.
Right.
This could be lubiprostone. It could be linaclotide. So that's how we're dealing with the constipation.
Right.
If they have more diarrhea, there are medications like what's called allocetrone, which blocks the absorption, which increases absorption, and you have changed diarrhea to a more normal stool. Elixatoline, these are agents that can be used. When you have more pain, you can look at antispasmodics, but then you need to move into the antidepressant category.
Right.
Because these are brain-gut disorders, the medications used in psychiatry for anxiety, depression are also used for abdominal pain.
Do you find you have to get across the stigma of psychiatric medication with some patients?
No question about it. If you say to a patient, you have irritable bowel, I want to put you on an antidepressant, that's not the way to do it. From communication skills, the patient will say, I'm not depressed, I'm not crazy. And they may not be. In fact, most are not.
Yeah.
I think that the point you have to look at now is that these, what are called antidepressants, is not the proper term.
Right.
We call them neuromodulators now. They affect the neural system, the brain-gut axis. And so we say to them, you have irritable bowel syndrome, I'm going to put you on a medication that's been called an antidepressant, but we use it differently. Might say aspirin can be used for pain, aspirin can be used to prevent a heart attack. Different medications have different functions. In the GI tract, we borrow from psychiatry to affect gut functioning through the use of these neuromodulators.
Right. That's an interesting way of doing it. Is there any place for behavior therapy?
Yes, and as I mentioned earlier, we're talking about disorders of gut-brain regulation. Patients who have these conditions become anxious, they become depressed. That anxiety and depression feeds back, it lowers pain threshold, it worsens motility, so they're caught in a vicious cycle. We have patients who won't go out. They'll be afraid, they have to know where the bathroom is. All of those anxieties, all of that focus on their symptoms, we call hypervigilance, selective attention, is modifiable through psychologic interventions. The one that's most recognized is cognitive behavioral therapy, which trains patients to rethink the magnitude or the impact of these conditions.
You're obviously involved in future developments and research. Can you give us an outline of where you see the condition and its treatment developing over the next, say, 10 to 15 years?
Sure. Again, it depends on the component that we're talking about. When we talk about irritable bowel, for example, we have altered mucosal immune regulation. The lining of the gut can become leaky, so to speak. So medications that might affect that regulation is one area. The microflora, we talk about dysbiosis. Nowadays, we really use like a canon. We use antibiotics or probiotics, but I think there'll be more profound, more precise kinds of treatments. We just saw at the meeting here that one of the innovations is looking at bacteriophages, which are viruses that can selectively identify the bad bacteria and eliminate them. When we get into the brain-gut dysfunction, I think there's going to be a role for more precise neuromodulators that affect pain regulation. So I think these are I think we're going to look at these components and drill down on the more precise treatments for them.
So it sounds like we can be fairly optimistic about the advance of medicine, certainly in this area. You mentioned earlier your work with the Rome Foundation. It's now been in existence for 25 years. What are its developments and what do you see as the future plans for the Rome Foundation?
Well, again, the Rome Foundation, when we began it, was to fill what we call a gap need. There was no way to categorize these conditions to do research. And once we did that, the categorization led to an explosion of research that's going on now because we now have these symptoms. But it's one of the chair of the Women's Committee called it team science because we have 123 investigators around the world, all experts in these conditions. And we use what was called the Delphi message. First of all, let me say that becoming a part of the Rome Foundation is something that people really want to do if they're involved in the field. We function much like the Institute of Medicine. We identify a need, we identify the best people, we ask them to go on a committee, and we work by consensus. We call it the Delphi approach, which really means that you bring experts together. What happens? Well, in the beginning, everybody thinks they know everything, and they will say they know what's best. But after a few days, you begin to harmonize, and the rough edges are evened out, and you come to consensus. And that's based on evidence in the literature. And so those committees form chapters, and those chapters are the basis for understanding these functional GI disorders. The Rome books, they're 2-volume set, and the Rome books are really a compendium, a Bible, so to speak, of knowledge. Since 2010, we moved on to say we want to expand into other cultures, which I've mentioned to you. Mm-hmm. We want to expand into primary care, and we want to have an educational message. These criteria were for research and academicians. What about the practitioner? That's where we developed diagnostic algorithms. The diagnostic algorithms give people a pathway for diagnosis. The MD, multidimensional clinical profile, is for treatment, and I want to say something about that, in that having a diagnosis doesn't mean a specific treatment. Patients who are seen in primary care with mild symptoms, as I mentioned, are treated differently with severe symptoms. So we basically decide treatment based on several components. What's the diagnosis, irritable bowel or dyspepsia? What is the subcategorization? Is it post-infection? Is it diarrhea predominant? Is it constipation predominant? What is the quality of life? We have a question, how much is this affecting your life? If you have more disruption in your life, you use more treatments. What are the psychosocial comorbidities? If you have anxiety and depression, you approach that with medication or psychological intervention. And what are the physiologic components? Do you have fecal incontinence? Do you have biomarkers? Biomarkers is the big thing these days. What are the specific biological substrates that you could treat more precisely? Using that profile, we can now go on and more precisely define the treatment.
You've also done studies on the link to, and you mentioned it before, to trauma and abuse. Could you just expand on that and how it affects the whole fertility?
Yeah, I think that's a 25-year research program that we have done, and it's been a lot of publications, and it's been very gratifying to see the change in the way physicians look at it now. Back then, when you mentioned that they didn't want to hear about it, they felt uncomfortable asking about it, and nowadays it's standard for residents in medicine to ask about this because of its impact on the health condition. So back then we were starting to identify that patients with the more severe symptoms often would disclose, if you had proper communication skills, this history of physical or sexual or emotional abuse. And that then led us to do a survey in our clinic. And what we found was that up to 50% of women who came to our clinic reported a history of abuse, very different from the general population where it might be 10 or 15%. That led us to do a NIH study where we began to find that not only was it reported, but a history of abuse would then lead to more severe symptoms. Fast forward 10 or 15 years, the work of brain imaging was beginning. And we were finding in brain imaging that patients with irritable bowel had an abnormality in an area of the brain called the cingulate cortex, and that abnormality was associated with greater symptoms. So we came up with the idea maybe the history of early trauma or abuse might in some way affect this area. And so what we did is a study with brain imaging, and we then showed that patients with an abuse history who have more pain also have an abnormality in this interface between emotion and pain regulation. That then led to additional work looking at the Gulf War vets. I was on the Institute of Medicine committee that looked at the Gulf War vets who came back with post-traumatic stress, irritable bowel syndrome, and we found the same thing, that the trauma of war can affect regulation between the brain and the body, or brain and gut. And as a result of that, now the VA system will provide compensation for soldiers who develop these conditions.
Whilst your expertise is in gastroenterology and psychiatry, do you see any connection between psychiatric or, when you said the brain-gut interaction, presumably there's also a brain-cardiac, brain-lung interaction with other symptoms?
Yes, but
Yeah.
no organ is as hardwired to the brain
Right.
as the gut. You have, in the embryo, you have the neural crest. And the neural crest differentiates as the embryo forms into the brain and the spinal cord. And the spinal cord sends down ganglia in the embryo into the GI tract. And that forms its own nervous system. So we have what's called the enteric nervous system. There are as many neurons in the gut as there are in the spinal cord. No other organ has that rich a connection. Just think about it in everyday life. Someone is about to give a speech, they may get diarrhea. They travel out of the country, they get constipated. Why? Because they don't want to use toilets in other places. So they hold back, they condition themselves. So we know that there's a close connection between the brain and the gut, much more so than other organs. And it goes both ways. If you take rats and you stretch their bowel and produce pain, the locus ceruleus in the brain fires. This is an anxiety center. And patients with GI disorders, often, particularly pain, often have a great deal of anxiety. This is commonly seen. So we have to get away from that dualism. We have to say that you get into a vicious cycle. You have IBS, you have pain, you have diarrhea, you're fearful of incontinence, that produces anxiety. It produces, as I mentioned, hypervigilance. You don't want to leave the house. You want to know where the bathrooms are. Your anxiety lowers your pain threshold. It makes your bowel symptoms worse. So you're caught in this vicious cycle. This is how the brain gut is dysfunctional and how we try to repair it. Now, I would also say that psychiatric comorbidities do exist. The vast majority of people with IBS do not have abnormalities, and they're functioning very well. But some of our research has shown the ones who go to the doctor with more frequently with more severe symptoms usually have comorbidities of anxiety, depression, somatization, and things like that. Yeah. So they're really caught in this vicious cycle. And you really have to work with their emotional state as well as their physical state.
Obviously, as a working clinician, you have success stories. Can you give us a brief outline on one of the cases that you've treated with great satisfaction?
This is one that actually has just been accepted by the American Journal of Medicine. Let's call this person Katie, and it's Katie's story. And what we decided to do, we approached the journal, and they were very excited about it, is I wrote my story of her, and she wrote her story of me. And they'll be published concurrently in the journal. Katie came to me, the nature of my practice, because of my work, is to see patients with difficult to diagnose and manage functional GI conditions or GI conditions in general. It includes inflammatory bowel disease. And the patients are referred, half of them are from out of state or out of the country. So I was referred this patient through a program, a national program that selects the doctors to match the patients. And this patient had been to the Mayo Clinic, the Cleveland Clinic, to many doctors, was very dissatisfied, was doing very poorly. Now, her symptoms, this was in summer of 2015, were, from a medical standpoint, irritable bowel syndrome with diarrhea and functional dyspepsia, which meant that she had abdominal pain and cramps with diarrhea, and she had early satiety, or when she ate, she'd feel full very quickly, and that would make her feel uncomfortable. Now, this is critical because her story began that she was having these symptoms, and in addition to that, in her early 20s, she developed type 1 diabetes. That diabetes got controlled, but she began to think that in order to control her symptoms, that her diabetes must be controlled as well, and she became over-involved in controlling her food. She became what you would call orthorexic. She became fearful of eating everything, sugary foods, gluten, high fats, and she lost 30 pounds. And in the process of this, she became so obsessed with the symptoms that she would check her blood sugar 10 times a day, constantly. Now, this got made worse, getting into the doctor-patient communication, because she went to a doctor and the doctor said, there's nothing wrong with you. She went to another doctor and said, well, you have a little bit high sugar. This is before the diabetes. Just watch your diet. Another one said, you just have to learn to relax. She went to another gastroenterologist who said, who did a gastric emptying study and said, oh, you have gastroparesis. In fact, she had some delayed emptying, but it was not clinically meaningful. And she said, gastroparesis. And the doctor said, you've got the stomach like an 80-year-old. This was to be reassuring.
Yeah.
The doctor said that, and she said, my God, I'm 20 years old. What am I going to be like when I'm 80? That led her into this vicious cycle because every time she ate, what she really had was dyspepsia, which was different than gastroparesis, and she felt that she had to control what she ate. Well, as a result of this, she lost the weight. She became really orthorexic. She wouldn't eat. She was anxious, depressed, stopped working. She was a special education teacher, went at home, stayed in bed all the time. She came to see us. And I think what we did that was different was, first, as I mentioned earlier, we legitimized that these symptoms are real. She has irritable bowel syndrome. She has dyspepsia. Here are the criteria. This is what you had. Very reassuring to her to have that. In addition, we said, now we can work on this together. And in her story, she said, we can work on this together. No doctor has ever said that. It offloaded the sense of responsibility that she felt on herself. Her self-esteem was plummeting. She felt like a failure. She couldn't control her symptoms. Doctors were not really helping her. So we gave her the opportunity to really help manage with myself as a cheerleader, so to speak. In addition to that, we used the right medications. We put her on buspirone, which helps the stomach relax properly. We put her on an antidepressant, an SNRI agent called duloxetine, which helped with the pain regulation. We put her on rifaximin, which was an antibiotic that helps the dysbiosis. So we did all the proper treatments, and we sent her to a psychologist to do cognitive behavioral therapy. Within 5 months, she had gained back the 30 pounds, went back to work, had a sense of control over her illness, and that's the story. Now, what did we do? We legitimized the condition. We provided the proper treatment. We gave her the proper diagnosis. And in the end, she took control and felt back where she was before.
Yeah. Which ideally should happen at every consultation, but obviously doesn't.
You have to do the proper diagnosis, proper understanding of the condition, explaining it to the patient, and then providing the proper medication, and in a way that's communicated properly.
I think that's a good place to end it. Thank you very much for your profound wisdom today. Thank you.
Thanks very much.